Hello, welcome to this Retina Radar podcast. I'm your host, Arshad Khanani from CRI Associates. Today, I'm joined by Dr. Diana Do, who is Vice Chair for Clinical Affairs and Professor of Ophthalmology at the Byers Eye Institute of Stanford University School of Medicine. In this episode, we'll summarize new evidence and real-world studies regarding the management of DME. Welcome, Diana.
It's always a pleasure to join you, Arshad.
We are so honored to have you, somebody as experienced and an international KOL and somebody who has really moved the space forward over the last decade plus. So we are really excited to have you today talk about DME. But before we get started, we usually have a few questions for our faculty members so that the audience can actually learn more about you. So let's start with the first one. Tell us, Diana, how did you end up in Retina? What drove you there?
Well, thank you for asking more of these personal questions. My father actually was a family physician, and he was, in fact, the first Vietnamese physician practicing in San Francisco. He really inspired me to pursue a career in medicine. When I entered medical school, of course, I kept a very open mind, and I gravitated to ophthalmology because vision is so essential, and patients are very motivated to save and improve their vision. The field of retina is particularly most enjoyable to me because it allows me to combine surgery with cutting edge clinical care and research.
I think that sounds great. Having a physician in the family obviously helps you, and to see the benefit, obviously helping patients. I did not have any physicians in my family, but I actually ended up being a physician because I visited many physicians with my grandmother, especially some ophthalmologists. And it's so interesting that all of us have different reasons to go into the specialty we are in. Now, let's talk about your hobbies. What's your favorite hobby, Diana?
I used to be very active in outdoor sports, but due to some knee injuries, now my favorite hobby is being a manager for my twin girls' club soccer team. And it's really enjoyable to watch these 11-year-old girls play competitive soccer and just show their leadership skills on the field and off the pitch. And it's really inspiring to help manage the team as they try their best in competitive soccer world.
Great. That sounds like an exciting job, but a full-time job.
Yes, it's my third full-time job now.
Yeah, the other two being a physician and a mom.
Exactly. You know that as being a father to four girls yourself and being a full-time retina leader and surgeon.
Yeah, it's not easy. I don't know how you do it. My wife obviously takes the credit of helping out with our four daughters. So yeah, soccer. That's great. I used to play soccer back in the day, and I think it's a great sport, right? You need to be in good shape physically, and at the same time, you need to be a team player. So that's great that you do that. Thank you for doing that. So let's just dive into DME management. I know you have been involved with all the DME trials. You have published. You are the lead author for many of these available therapies. Tell us how you're managing your patients with DME these days versus what we did before anti-VEGF agents came out.
I think diabetic macular edema is a very treatable condition, and we're fortunate nowadays to have so many good options. Of course, in my clinical practice, the first line agent for patients who come in with center involved diabetic macular edema and who are symptomatic is intravitreal anti VEGF agents. Obviously, we've had over a decade of experience with intravitreal anti VEGF therapies, and there is clear level 1 evidence for the use of these medicines to treat diabetic macular edema. In fact, I've started treating patients earlier, even when they only have mild amounts of diabetic macular edema, because the evidence has shown if you delay treatment, those eyes don't always achieve the vision gains as eyes who've had more prompt therapy. And so I individualize the approach to each patient, but I really try to engage them to share with them the importance of adherence and the importance of frequent visits and treatments in order to preserve and improve their vision.
I think that anti-VEGF agents have really revolutionized, right, what we do for these patients and how we can help them achieve the best outcomes. So tell us about your practice. Obviously, all our practices are different based on our insurance and payer mix. Tell us how you are starting anti-VEGF. Are you going with off-label bevacizumab? Are you using first generation agents? Are you using second generation agents? How are you treating these patients, and how the recent data on faricimab as well as high dose of aflibercept have changed your practice?
I think the vast majority of retina specialists, including myself, are restricted to step therapy. And thus, we have to start off with off label bevacizumab because that's the most cost effective agent that insurance companies mandate us to use. I will start off with bevacizumab initially, but if patients do not have an optimal outcome, that is, the vision hasn't improved significantly, or the diabetic macular edema still persists despite several bevacizumab injections, I will advocate to switching to an FDA approved anti VEGF agent. Prior to the approval of aflibercept 8 milligrams and faricimab 6 milligrams, I was using aflibercept 2 milligrams as my preferred FDA approved agent because of the evidence from clinical trials, from the DRCR network, and from the Vivid and Vista studies, which showed the efficacy and safety of aflibercept 2 milligrams. But more recently, we have had the new approval of aflibercept 8 milligrams for diabetic macular edema, diabetic retinopathy, and neovascular AMD. In addition, the FDA also approved faricimab, which is the first bispecific antibody that inhibits both VEGF and angiopoietin 2. I think as a retina specialist now, I am gravitating to using either aflibercept 8 milligrams or faricimab as my go-to agent after a patient does not have an optimal outcome with bevacizumab. Is that what you're using, Arshad?
Yeah, so my practice is a little bit different, Diana. Like many of my patients have full coverage because they're either retiring in Reno Tahoe area or they're working for companies that have good commercial insurances. So I actually start with a branded agent currently, and I used to obviously use first generation agents, and now I'm actually shifting gears towards second generation agent. We started using faricimab after the approval, and we have seen great durability and anatomic outcomes and comparable safety so far in our practice. And then with the high dose aflibercept, we just have access to it, so we started using it in our patients to see how it works. For me, comparing the second generation agents is important, whether high dose aflibercept or faricimab, which one can drive the retina better for our patients? Is there patient subtypes that can benefit from one to other? And just like any new agent, the high dose aflibercept currently I'm using in patients who were previously treated with faricimab, and trying to see how much they improve or what we can do to help those patients. I think at the end of the day, it's great to have options, right? And we are so lucky that we have multiple agents available for our patients. And looking at the data, the recent photon data that you presented at AAO Sub Day is quite impressive. Can you share that with us?
Sure. I had the privilege of presenting the 2-year data from the Photon clinical trial, which evaluated aflibercept 8 milligrams compared to aflibercept 2 milligrams for diabetic macular edema. The results were very promising. Aflibercept 8 milligrams, whether dosed every 12 weeks or every 16 weeks after only 3 initial monthly injections, met the primary endpoint at 1 year, and the vision benefits were sustained through 2 years of follow-up and treatment. More importantly, as we talked about the need for more durable anti-VEGF therapies, aflibercept 8 milligrams, 88% of patients randomized to the 12-week dosing arm maintained these randomized intervals through 2 years. And 84% of patients randomized to aflibercept 8 milligrams every 16 weeks also maintained this dosing interval through 2 years. That's quite remarkable because it can answer that unmet need in clinical practice where it's more challenging to have patients come back frequently with the first generation anti-VEGF agents.
I totally agree with you. I think seeing the durability results with the second generation agents, I think is remarkable how hopefully we can have better outcomes for our patients, especially with DME, where we know that patients don't follow up for their appointments due to multiple different reasons. And I'm hoping that with this new agents, we're able to minimize their treatment burden. And it's interesting, obviously, clinical trials have criteria and inclusion exclusion that is very different than real world practice. And I think it will be important to see how the agents work in real world practice. And that's why we, did the Faricimab real world study, which has been a lot of work for Truckee for NAMD and Tahoe for DME without any sponsor, just to look at that. And I think it'll be great to see some real world data on aflibercept high dose also to establish the anatomic outcomes compared to other agents. And, as you recall, Yosemite and Rhine, Q 12-week dosing was 80% approximately, and then 16-week dosing was 60%. And so I think what we are seeing is the second generation agents really helping us address that biggest unmet need of durability. And safety wise, Diana, in the Photon study, I know it's a 70 microliter injection. As far as I remember, there were no new safety signals, but I think in clinical practice, we need to monitor, obviously, because of the increased volume.
Yes, I think safety is always important with any new medication. And fortunately, in the clinical trials for aflibercept 8 milligrams, there were no safety signals. In fact, the safety profile for 8 milligrams was similar to that of aflibercept 2 milligrams, with very low rates of intraocular inflammation. And there were no cases of retinal vasculitis or retinal artery occlusion. When we looked specifically at intraocular pressure, we saw throughout the study there were no serious adverse events related to elevated intraocular pressure, and it appeared that the 70 microliter volume was well tolerated.
Yeah, that's been my experience too, injecting it in real world, that, we just, the volume is not an issue. I think what I'm interested, personally in, I'm doing with newer agents, even for GA drugs, baseline nerve fiber layer, just to see if the volume has any effect on it. And I think that's another interesting study for one of our fellows to analyze if higher volumes can affect, retinal nerve fiber layer. But yeah, personally, have had no issues. And of course, my experience is very limited at this point. I've injected maybe 5 or 6 patients because it was just recently available. So other exciting things, Diana, PDS with ranibizumab, I presented the data for the Pagoda study, meeting the primary endpoint where PDS refill exchange every 6 months was comparable to Lucentis 0.5 milligram monthly non-inferiority trial. Obviously, PDS is a surgical device, and we have evolved over the last 5 years or so in terms of surgical technique. And of course, it is only for a subset of patients. It's not FDA approved, but any thoughts on PDS to treat a chronic disease like DME?
Yes, the port delivery system is an exciting development because it allows for a continuous delivery of ranibizumab for at least a 6-month period. And after the surgical implant, the refills can be performed in the office. Of course, the biggest factor for the port delivery system is just the safety aspects, because there was a slightly increased risk of endophthalmitis or vitreous hemorrhage. More recently, the PDS was recalled by the manufacturer because of cases of septum dislodgement in implants during the refill procedure. Right now, the PDS new cases cannot be implanted because of this recall, and the manufacturer is working on improving the design of the PDS in order for it to be used again in clinical practice. So we're awaiting their updates.
The key thing is that it's a surgical procedure. It's never going to be as safe as injections, but are there patients that are losing vision because of undertreatment? Can we help those subset of patients? And, being part of the program over the last decade, my surgical technique has improved so much compared to what it was 5 years ago. And I think we continue to learn as a field about the procedure itself. The patients are super happy. In my opinion, I had the opportunity to implant commercial PDS before it was recalled, and those patients are very satisfied. So I think it fits in on a subset of patients as long as the physician and patients understand the risk and benefits. And hopefully, from recent news is that it will be back in the clinical trials hopefully early next year, and then maybe have availability for commercially for NAMD hopefully later next year. But of course the DME and DR approval is not there yet, but we're hoping that we'll get there. So Diana, before we dive into some more questions about your career and other things, anything from the real world study? I know far retina DME and other studies have been out there for real world faricimab, and what kind of things you look for in real world studies, and what would you like to see for real world studies for these second generation agents?
I think it is important to have these post-approval studies run by clinicians to evaluate how these new agents are used in clinical practice. You've led the Truckee study and the Tahoe study looking at faricimab, and the FAR Retina study evaluated the use of faricimab in diabetic macular edema by utilizing the data from the IRIS registry from the American Academy of Ophthalmology. And in this retrospective database study, the investigators looked at about 3,000 eyes, and these eyes were both, some of them were treatment naive. The vast majority had prior experience with anti-VEGF agents. And the purpose of the study was to look at how faricimab was being used in patients within this IRIS registry. And they saw that 75% of patients had been switched from aflibercept to faricimab to try to treat their diabetic macular edema. And the initial data showed that 63% of eyes with diabetic macular edema could have an extension between injections, and about many of them were able to maintain their vision. Of course, when you look at these retrospective database studies, you have to understand that there are limitations with these type of data, including, the vision is not best corrected visual acuity. We don't have OCT data. And also, we don't know exactly why these patients were extended. Were there other circumstances that did not allow them to come back sooner, or was it truly the durability of the new medicine? But nevertheless, I think these databases are important because it gives us more experience with what these agents are being utilized in clinical practice, and also gives us more information about possible safety events as well.
No, I totally agree. Excellent summary. I mean, I think, as long as we understand the limitations, I think they really help us understand the real world usage. And I think it's important to have these real world studies, as you mentioned. And I think even for high dose of aflibercept, we hope that we will have that data in the near future to see how these second generation agents are helping our patients compared to first generation. Okay, a couple of other personal questions, Diana, before we sign off. Tell us about the career achievement that you are most proud of.
I think balancing my personal and professional lives is very important to me. And my greatest achievement is, of course, being a mother to three amazing young girls, while simultaneously fulfilling my professional goals of being a retina surgeon. I think every working parent, has the challenge of work-life balance, and we are constantly trying our best to fulfill all our obligations while doing it gracefully for our children and families.
No, that is so great. I met your three daughters, and they're absolutely amazing. And not only just you, you also have to take care of the whole family. And of course, your husband, Juan, being a retina specialist, it's not easy, all of you to balance, but I think you have done an amazing job. And I think that is so nice to see that you can actually be so successful, internationally renowned, and at the same time be the best mom. So I think that's so great to see.
Same for you, Arshad, too. I mean, you and your wife both work diligently and also raise four amazing young children. So many of our retina colleagues are in the same position as we are, balancing personal and professional lives. So it's inspiring to see everybody do this.
No, yeah, and it's not easy, right? but but we but we all do it, and I think we are very proud of what we are doing, right? Helping patients, doing these trials and talks and interacting with each other like we are doing here, and at the same time, you know, being there for our families and our kids, and hopefully, show them and serve as their role models. And I know you are a role model for all three of your daughters. And then the last question, Diana, it's too early. You're too young, but how do you want to be remembered once you retire?
I think the theme is similar. I want to be remembered as an amazing mother and, of course, as an inspirational role model for them, while also being the best retina surgeon to my patients. I think being a mother who is actively present in the daily lives of my three children is a top priority for me, and I find it extremely enjoyable and gratifying to be able to do this. Um, we mentioned it's very challenging to be a full-time parent, retina surgeon, and physician scientist, but trying to balance all of those activities brings me great joy. And I hope I'm able to do that indefinitely. And I look forward to future conversations with you and sharing um, our professional and personal achievements together with each other and our colleagues, because that's what makes life and the retina community so special.
I mean, you have always been a role model for me, and I'm sure, as I said, I've met your daughters, and you're clearly a role model for them, and also, for the community. I think you have the reputation of being friendly, being patient oriented, and also always pushing the field forward. So, Diana, thank you for the excellent discussion. And I also want to thank our audience for listening. Please remember to take the post test and evaluation to receive CE credit and to tune in for additional episodes within the podcast series. I'm signing off. Diana Doe, thank you again for being here.